There you go, Mike.
Thank you. All right, we'll call the meeting to order. It's 10 o'clock. And at this time, Mr. Coffey, would you be so good as establish a quorum by calling roll of the members?
Yes, sir. Mike Cottle, Chair.
I'm here.
Yvonne Egan,
Here.
Chris Kaiser,
Here.
Barry Martin. Here. Rainer Mullins. Rainer Mullins.
Mr. Cooper, I think you were texting with him a few minutes ago. Did he intend to be on today?
He did intend, Mr. Cottle. I will send him an email and follow up with him.
Okay. All right.
You do have a quorum.
Okay. Now, our next item is number 3, approval of minutes from previous meetings. I did not receive a copy of those minutes. I did receive a copy of the transcript. Did everyone else receive a copy of the minutes?
If I could, I spoke with Medicaid. They have a new court reporter. So for the last meeting, the transcript is taking place of the minutes.
All right.
And that will be the case moving forward as well.
We will not be getting the minutes anymore.
No, sir. We had our normal court reporter who handles this had to step down for personal reasons. And the other court reporters that we have do not do the minutes. And so I think that was something that reporter did that I kind of discovered when I took over, that it wasn't across the board. Everyone wasn't getting the same type of minutes and transcripts. So since we changed the reporters, we just moved to the transcripts.
I've found that the summary, what we used as our minutes, was very helpful. I'm wondering if that can be included anyway, and if it's not just a personal decision.
I can take that up the chain to Veronica, and I can also reach out to the court reporters. But most of them don't do the minutes like the other one did, but I will dig into that for you.
I don't know about everybody else, but for me, if you could find one that does, it would be very beneficial to us, I think.
This is Yvonne. I would agree with Mike. I think the minutes is a summary of a lot of conversation. And they're very useful. If we could try to get those reinstated in the future, I would request that.
I also hope that it can go back to the way it was, where we get them within a couple of weeks or so of the meeting, rather than the last week or so in this case.
I understand it was a last minute transition.
At a state level, and it's industry based. The industry supports it, but they have been short term. They've done a couple years to look at it, and I don't know of any that have been long.
Is someone speaking about the court reporter or someone not muted? Okay, I think maybe that may have been someone not muted. So
Okay.
I apologize about that. Guys, if you're not speaking, if you could please mute, because it does help the court reporter so that we don't have a lot of clutter in the background. But Mike, I will take that concern to Veronica, and I will also reach out to the court reporters and see what I can do. I have asked before, and I was told that they didn't do minutes, but I can always ask again.
Is once we had that excellent level of service before, it's kind of hard to go back for less. And it's not my purpose to get on anybody or nothing else, but it certainly would help us, Veronica, if we could get those things timely and with the minutes or summary of the transcription. All right, that being said, I have a change in the transcript. It left Raynard Mullins as being off. On the front page, it says he's present, but in the column of quorum, it did not show that he was called. And not only was he present, but he did that excellent presentation concerning the state of the dental availability in the state. So certainly would want to make that correction, show he was here. All of that being said, then using the transcript as the minutes for this meeting, is there any other additions, subtractions, corrections that need to be made? By your silence, I'm approving there are none. Therefore, would a member like to make a motion to approve the minutes as was distributed?
I'll
I'll
make,
make a motion.
oh, I'm sorry, go ahead.
Mike.
Mike,
Yes,
second that.
okay.
Mike, this is Rayner. I missed the early part of the discussion, but I assume the minutes include the two recommendations, dental recommendations.
They did.
Okay, as drafted and approved by the MAC, then I guess.
Okay.
So I'm supportive in that sense.
Right. So motion made by Barry then and second by Yvonne?
Yes.
Okay. All those in favor, please say aye. All those opposed likewise. Motion carries unanimously. Let's go to the old business in this little different format. So first thing listed under 4A would be potential of future in-person meetings. And it's got DMS. Last time we had a discussion about that. I think this is there. You had a small meeting room available that would sit about 15 people at the table and space for seating along the wall. But the large rooms, you'd not been able to work out anything at that point. And I believe that you and this would be Veronica I'm talking about. I believe that you and Molly Lewis was going to get together and discuss that more about potentially KPCA hosting that. So let's open the discussion on that basis then.
And I apologize because Molly and I did not, this is Veronica Cease with Medicaid. Molly and I did not have that conversation. However, I mean, certainly our conference room that is capable for hybrid could certainly fit the TAC members and you know, a small audience. It's a small room that feels comfortable coming to an in-person meeting. And so we're happy to open that up for an in-person meeting if that's the desire, as a hybrid, if that's the desire of the TAC. And I would recommend a hybrid because, you know, my understanding again is that the increase in participation has been one of the benefits of using Zoom. And so it would be our recommendation. What some of the other TACs are doing is talking about having one in-person meeting that would still have a hybrid component to it, but having one in-person meeting and then the rest of the TAC meetings to be all virtual. So just to kind of let you know what other TACs are considering. We don't have a problem if KPCA wants to host, if they have a little bit of a bigger room. We'll go, we'll certainly accommodate any requests along those lines. We did find out we cannot use LRC. They will not allow outside entities to utilize their virtual equipment. So that would have been one of our, I think, better places to go because of the size of the rooms to be able to accommodate folks. But so those are, I think, our current options. The big meeting space that the Department of Public Health has is still under construction, although I heard today that there's some light at the end of the tunnel that they should have that up and going maybe in the next 60 days. So we could reevaluate the use of that space. I think my biggest concern is just ensuring we have enough space for anybody that would want to come in person, because we have to, if it's going to be a public meeting open to the public, we have to be able to accommodate everybody who wants to come in person. And so we're just, concerned about fitting everybody into a small conference room that can't meet that purpose.
I think all the members went on record about their feelings, and all of us likes being able to attend by Justin Deeringer. You're need to mute, please. Thank you. But like the hybrid system where we can on reasons for important calls have it in person. I kind of like I like what you said about maybe designating one meeting a year for in person, and the other ones, unless something special was to come up, be available as telehealth or Zoom call with the option to attend.
Yeah, and Mike, several of those TACs that are planning that are planning to do that in the fall, and to give us some additional time to try to secure a room that's large enough to accommodate anybody who wants to attend in person.
So would you be getting us a fancy meeting room in some 5-star hotel or anything?
No, I can definitely say no to that. But what we do hope is that the public health space will definitely be available by then, and we can see about scheduling that space. Or if it's not available, then look for some. It gives us plenty of time to look for some other space. I'm not sure what the size of KPCA and what they can accommodate.
Yeah. So is Molly on here?
She is not, Mr. Cottle, but KPCA can accommodate about what DMS's conference room can accommodate. We would be happy to host it, but again, the space would be limited.
Let's see, I believe there was some restrictions, maybe about the use of equipment on an off-site location or something last time. Is that just in my mind, or does that ring a bell?
Is that directed to DMS?
Okay, all right.
Mike, this is Noel. I'll say, yeah, the last time we hosted here at KPCA, I was the assigned staff person for the committee. We do have equipment that can do that, but I'll just second Teresa. With the addition of a row of cubicles, we've lost the larger amount of space that we had here at KPCA. So like Teresa said, we can probably accommodate just as many as DMS could in their space, but we also have a little bit of a limitation on parking. When we did host that one time, our parking lot filled up. Right now, it's not a big deal because we can park behind the building where the child support building is over here in Frankfurt. But I don't know, at what point they'll start bringing folks back into the office. I don't know how that's going to work for that department. And also, we had a lot of people spill over into the businesses around us, and had a couple of those folks come and ask us, hey, what's going on? We don't have any parking for our customers and our patients and things like that. So I don't know if it would be, suitable at this time, for KPCA to host, where not so much for the space, because that's equal to DMS, but with some of those other issues with parking and things like that.
Okay, so I think it's further obvious that right now we need to continue virtually with the ideal of as DMS is able to expand their capabilities, that we could then follow up on Veronica's suggestion about designating one meeting a year as in person. Does that sound reasonable to the members of the board?
Yes, this is Chris.
And I think if we can't meet the capacity load, maybe we come up with suggested members, definitely the TAC members, certain Medicaid staff members, and maybe one representative from each MCO to attend, to just limit the physical meeting, and have the other people that can do remotely.
So the open meetings law won't allow us to limit. If we do an in-person, if we give an in-person capability, we have to be able to accommodate anybody who will want to attend in person. So we are not allowed to limit attendance.
Right.
And that's the struggle we have. We don't know if we're going to have 15 or if we're going to have 50. So we have to be able to just, like, there's 48 people on the call today. We don't know, are 48 going to show up in person? I would think not. And logic would say probably not, especially if we have a hybrid option where people can still participate via Zoom. But we have to be able to accommodate all of the people that come if they come in person.
Well, you're probably having the same problem with all the other TACs. So
We are.
If you find a solution for the other TACs, I guess we could apply it for us as well.
So for our purposes, we'll leave it on the agenda for next meeting on September the 1st to be a status update, and we will continue to do so until the department finds a solution or recommendation. Having said that, you also was telling us last time, Veronica, about the new legislation that was passed on meetings, and the department was going to analyze that for its impact and on meetings such as technical advisory committees and the MAC. So at this time, have you all completed that review, and what do you see the impact to be?
So we don't believe that it's going to change the way we conduct meetings now. Again, I think the only difficulty there is that if we decide to do a hybrid where there's going to be an in-person option, we just have to accommodate anybody for that in-person option.
Okay. All right. Is there any other questions of Veronica before we move on to the next item on the agenda?
This is Chase Coffey with the Primary Care Association. I just messaged you, Veronica, but I'll go ahead and ask just for transparency's sake. Has anyone looked into the conference rooms at the transportation building? I know that they have some rather large conference rooms that they added when they finished that building, including an auditorium.
So we checked on that. It's been a while. And when we checked on it, they were not allowing other agencies to utilize the space. Some of that, I think, was pandemic related. And so they weren't opening them up for use. We could certainly check on their availability, because they do have some of the larger meeting space. And as long as it can, I think the other thing is, does it accommodate the hybrid? And so is it, do they have the technology that will allow, the key piece here is, all the members have to be on screen, and you have to be able to open it up so that everybody can talk, and so, does their technology allow for that? But thank you, Chase. We'll certainly follow back up with them.
Understood. Thank you, Veronica.
Next item is 4B, how to increase the level of primary care spending. I was going to ask Molly Lewis about that because I believe that's coming from the presentation she did last time. Mr. Coffey, who will we need to have speak on that one?
So Mike, this is Chase Coffey again. I always want to enter and say who I am for the transcriber. But when I went back and watched the May meeting that I wasn't able to attend, it sounded like you all would like to continue the discussion and that you all cut it short for time's sake. So I just wanted to add it on here. So it was brought back to everyone's minds for any continued discussion you all wanted to have on it.
So this was dealing, if I remember correctly, is dealing with Molly's presentation about basically the need for primary care spending to be increased so that things like social determinant could be addressed in clinics on a higher level.
Yes, sir.
We talked. Start with, does anyone want to speak to that? All right. Let's we'll talk with Molly and see if she wants to do a follow up on it the next meeting, since we're all kind of quiet right now. 4C, follow-up discussion on dental workforce recommendation. To that end, if you all will remember, and if you don't remember, please take the time to read in the transcript the excellent report that Rainer Mullins gave. And as part of that, a motion was made and approved to make that our presentation to the MAC, and it was presented to the MAC, and the MAC did vote favorably to take up that recommendation as had been drafted by Rainer and approved by this board. So having said that, that kind of puts it in the hands of DMS. So Veronica, can you bring us up to date what's happening then since the MAC incorporated in their recommendations?
Mike, I'd like to make a couple of comments before Veronica reports back, if that'd be okay.
Yes, sir.
This is Rainer Mullins. As Mike described, and many of you, including Veronica, are familiar, I've been dealing with dental workforce and dental policy in Kentucky for years, right in the middle of most of the policy frameworks. So the TAC and Mike asked me to help develop the recommendations. I think it's important to note that I've been the dental representative on the TAC, on the primary care TAC, for several years, both recently and in the past. And I'd like to get some observations on the record. Dental supply problems in Kentucky date back to the early 1990s, and it involved policy changes on the mix of in and out of state dental students and graduates in Kentucky. And we made these TAC recommendations before the recent announcement by UPAC of their intent to open a third dental college in Kentucky. And I think that even adds to their importance. Now, what else I would like to say is understanding this problem requires the availability of good dental workforce information, including dentist participation in Medicaid. And due to COVID, and several other considerations, I don't think we've had a comprehensive look at dental workforce since 2016-17. I was involved with that a bit with the cabinet and the state oral health program directed by Julie McKee, and it coincided with the development of a new oral health strategic plan for the state. And at that time, we identified some major dentist supply problems, including low participation of general dentists in Medicaid and related to the supply of dental specialty services, particularly oral surgery services. So the COVID epidemic, based on my experience, has likely increased this problem significantly. We have some documentation of that through KPCA, but to my knowledge, there hadn't been a good look at this since 2017, the spring of 2017. There have been some pending requests to look at Medicaid information that, for reasons I don't understand because I haven't been involved with it, the analysis of the Medicaid workforce information has kind of been stalled. And that's what's necessary to understand this problem. And for all of these reasons, that's why I made the dental TAC recommendations that I did. And Veronica, I go back a long way. I'm happy to try to help inform this policy in any way that I might. But now I'm going to go back to Mike's question. What discussions have you had in the cabinet, and what is the intent regarding these recommendations?
Thank you. So obviously we just got the recommendation, reviewed it. We haven't started deep diving into it yet. We're going to include the Secretary's office, the Office of Health Policy, which actually is the Office of now Data Analytics, but and I think include the Kentucky Dental Association in those conversations. And we've been pulling data because we've been asked to pull data around dental expenditures and rates. And so, it's definitely being discussed. The workforce, the overall dental workforce issue, I don't think Medicaid in particular, the cabinet to some degree have a lot of control over the dental schools and how many dentists graduate and remain in Kentucky, how many will take Medicaid patients. I've had problems with getting into my own dental office due to lack of hygienists. So, I think it's going to need a more statewide, various levels of government involvement, the legislature, because they have the power to create incentives and change the laws. The dental schools have the ability to, increase and incentivize dentists staying in the state, things like student loan forgiveness. So there are a lot of policies that we just don't have control over. But we're interested in trying to help, be at the table and try to help solve what the barriers are to access. Dental rates, increasing dental rates, I don't think will absolutely, result in an enormous increase in the number of dentists who accept Medicaid, because, some of them just don't accept anything other than private pay. So, I think it's going to have to be a very comprehensive approach to how to solve the workforce issue. And as I'm sure you're aware, it's not just in the dental community. We're facing that in the nursing community. We have a lot of provider types that are struggling with workforce. So how it's a challenging time now for, for us and I think again across the provider types to find out, well, what are the solution, what are the policies, that the small piece that Medicaid may attribute to that, but it's really more of a statewide policy issue. So all I can say is, we're initiating, what needs to happen as part of this. We'll certainly, Rainer, include you. And as I said, the Kentucky Dental Association and other folks, Dr. Bobrowski, who, has really on the dental TAC, if any of you attend the dental TAC, they have been grappling with the reimbursement issue, but also access issues, making sure that we have dentists across the state or have at least access in compliance with our network adequacy requirements. They've been working on it. And I think you have to start from, what does the data tell us, and kind of work from there.
I agree on the complexity, Veronica. We both an essential part of it, though, I believe, is the relationship between workforce supply, the total supply, and dentist participation in Medicaid. And I worked with Dr. Rich and the KDA and the cabinet on this for several years. And we gained a lot of understanding about this problem. And so, to my knowledge, that hadn't been updated since 2017. And so I go back to one of the things that Medicaid can certainly do is help inform with transparency, what's actually going on in the Medicaid program regarding dentist participation. Now, the other arm of this within the cabinet is clearly the state oral health program. And Julie McKee and also the licensure board and the supply aspects of this. Without combining the two, it's really not easy to understand the dynamics of what's going on. And it requires, as we reasoned out a few years ago, county level data. And that's what Medicaid can help inform. And I'm sure Julie, as we engage her in this discussion, will agree about the need to relate the total dental workforce data with that to get an accurate picture to help inform policy. And that's something that I believe you can do within Medicaid, that I would hope you would, because otherwise a lot of institutional memory and history and hard work for several years, collaborative work between the KDA, between Medicaid and the dental colleges would be lost, and you'd just be starting over. And that would not be a very good thing. In my opinion, it would result in much confusion and probably politicize the issue rather than get it supported by good, solid policy information. So those are the comments I would make. I would say historically, when these types of considerations have been done, there have been task force set up involving the KDA, both dental schools, and the state oral health program. And I would say in this case, certainly to include KPCA because of their role in assuring access for the underserved. So I would hope that that might be the eventual result, so that we could take a new updated look at what's actually occurring in Kentucky and decide what policies should be changed or added or deleted.
Rainer, this is Chris. I've got a quick question for you.
Sure.
So is data on the HPSA, the dental HPSA scores by county not available, or is it available for us to look at? Because like I said, I'm like you, I'm kind of curious as to what does that information point to in regard to underserved areas?
Well, we've got a problem that's well documented, not only by the HIPSA data, but a lot of other data, Chris, but that's not granular enough.
Mhm.
Really understand the supply issue that's going on. Just as a way of illustrating, in 2017, dentists were migrating out of Kentucky. We have an aging, I'm out of Eastern Kentucky and rural Kentucky, and headed into the central triangle of Lexington, Louisville, Northern Kentucky. That's tied to the economy primarily, and also to some of the problems with Medicaid reimbursement and the ability to sustain a successful financial model in these areas. But also, it's complicated by dental student debt, and they have not been relocating in the rural areas. They've been seeking employment opportunities in the corporate sector and in private practice in the more urban areas of Kentucky. Thus, you have a fairly severe workforce problem in rural Kentucky. And of course, it's even more complicated than that when you separate it out between the general dentist and the dental specialty services. Those are different policy issues that need to be looked at differently as far as the overall solutions to these problems. So I just stopped there, but I hope that it will get a serious look within the cabinet, and that will be driven by up-to-date oral health information that's put together by those who are very familiar with some of these dynamics, including Julie McKee and as Veronica pointed out, a long history within Medicaid using Medicaid dental information and counter information to help understand the supply problem.
Yeah, we are working, so the dental TAC has been working on a data request to develop a report that we can start running on probably a quarterly basis, but it includes the number of dentists and where they're located. It includes the expenditures, also down right now at the county level. We might have to pull that up to a regional level, but we're taking a look at it. And so, so that they can have something to monitor. They want to be able to kind of monitor what's going on in the workforce and with expenditures. It's based at the service level. So we can also see, expenditures across services.
Visits services are very important in the nature of services.
Yeah.
But also, not only dentist participation in Medicaid, but their level of participation.
Mm-hmm.
That
Right.
turned out to be a very critical issue when Dr. Rich and I looked at this previously, because what you found was that about 400 of 2,000 practicing general dentists in Kentucky actually participated at meaningful levels. And that was about 20%. And you had to get down and really look at the general dentist population to understand that and their participation. And that's much different than the supply of dentists that the cabinet shows participate in Medicaid, which is probably listed on the rosters 1,000 or more. And that's a very misleading piece if you don't understand the data and get very, very precise with what you're looking at. So I'm hoping that any report like that would take advantage of the past history and be informed by that. Otherwise, it'd be a very inaccurate report that'll go into the file and be useless.
So and that's why we're doing it at the expenditure level, because to your point, just because it may show 5 dentists in that county, if only 3 are submitting claims, that means the other 2 are not. And so that's why it is critical to look through that lens, and why we're pulling the data to only, to reflect who's actually billing for services, because that obviously shows participation.
Absolutely. And you also need the visit information, because that's also very important from the patient perspective and the access thing to understand the problem. Okay, yeah, this has probably gone a while, but I hope it's been a useful discussion. Again, I'm happy to inform it in any way I might. Most of you know I'm approaching 80 and I've been retired, but I'm still kicking around a bit, trying to help where I may. And obviously very committed still to try to see if we can help at least improve the current situation.
Rainer, a quick question. Do you participate in the dental TAC?
I have in the past, but I have not recently. But I will know most of those individuals, including Garth Burbowski, who chairs it. I know I've got a pretty good sense of that, because up until 2017, I was working with many of the same individuals on these issues to get a common approach to it. So I'm pretty sure I have at least some understanding of that. Another individual that was very involved was Bill Collins from Pikeville in this. And so there have been several dentists in recent years that have been actively trying to get this problem addressed through that dental TAC. It's been on the issue in significant ways, Barry. So.
I certainly like to see this stay on the agenda, and perhaps Veronica can give us a report and some more details at our next meeting in September.
Mike, I would only have one other comment. Obviously, with the addition of UPike into the mix, I would think they should be invited to participate in these discussions as they move forward too.
It's a good idea. There's another thing too, is LMU across the state line at Middlesboro is starting a inaugural class dental school this fall also. And that's something that should be looked at, and maybe it's something that they can be approached about working out some type of reciprocal agreement on in-state tuition for Kentuckians, or at least rural Kentuckians that border or nearby their location.
Suggestions.
Actually, I'm sorry, I didn't mean to cut you off, Rainer.
No, you didn't. I just said that's an excellent suggestion.
Okay. Well, I heard you the first time. I just wanted you to repeat that part about excellent suggestion. Okay. Ashley Gibson, KPCA, are you on here? Ashley promised us some information, current information on the number of students in both dental schools and the makeup of Kentucky versus out-of-state students at our last meeting. I was hoping that she would be here and have that information available. So would anybody from KPCA like to jump in then about that information, or where it's at in the compilation of it?
Mike, I will, if you want to go on to the next item, I will reach out to Ashley and see if she can hop on.
Okay, thank you. Then that's the last thing under old business. New business, a rate increase July 1, what it is, and will it be effective July 1? When that was made, we had not received any letters from the MEI increase. I think certainly we have, and I believe everybody else has by now, Veronica. But do you want to just talk a little bit in general about the MEI increase and how it's computed and things?
Absolutely. Thank you. First, let me say that we are human, and there was an error in the letter. There's not an error in the corresponding rate information, but the letter refers to a 1.2% MEI, and it's actually a 2.1% MEI. So we're going to be sending out updated letters just because we think it's important that we're capturing the accurate information in the letters. But again, in terms of the implementation and the actual rates, it is 2.1. We get that from Medicare. And right now our regs and state plan, the regulations and state plan allow for rate increases under 3 scenarios. One is the annual MEI. The other is scope of services. If there's a change in scope of services. And then the third is as a result of a desk review or audit. So we've been looking at understanding that the cost of living is actually quite high. And, we're a little surprised at how low the MEI ended up being. And we've been in discussions to see what are our options or discretion. Unfortunately, we've not come up with much of a solution because we are tied to that regulation and state plan. So I know, we're hearing from all provider types. I would have to say almost every provider type, how the current economic situation is affecting them, both from, we go back to talk about workforce, a struggle with recruiting and retaining a workforce as a result. So I can assure you it's not falling on deaf ears. We're just trying to figure out how do we help our providers within our budget, within our current laws and regulations. So that's the current situation.
Okay. Any of the members have any questions for Veronica related to this subject?
No, we just appreciate anything that you can do or the state can do to help us because 2.1% is definitely not reflective. And when you look at the basket that CMS uses or for the MEI, it doesn't include staffing and utilities and gas prices. It includes items that aren't necessarily a necessity and a business related item. So the MEI does not properly reflect what we're doing. So that's one thing. There's nothing we can do about that. But I actually wanted to put that on record, that anything that you can do to help us from the other perspective would be great, because we all know that the wage rate of inflation is a lot more than 2.1%.
Yeah, well, it was certainly so. All right, thank you for that, Veronica. Under 5B, discussion with MCOs to develop crosswalk of benefits for SUD patients in recovery. And I asked for that to be put on the agenda. We formed an organization along with ARH and Art Care called Help End Addiction for Life, or HEAL. We meet once a month, and at the last meeting, one of the representatives of one of the MCOs spoke up and discussed the benefits that they had for SUD patients, and it was remarkable, and we were not aware of it. So just like we talked about it and had a presentation to be able to give out about what all COVID benefits were, my thoughts are is that it would be great to have one with the input of the MCOs and develop as to what benefits they are for recovering SUD patients. To that end, and we had it on the agenda so that it would not blindside any of the MCOs when I asked them, we will get down to them in a minute, but that's reason there. And I'm going to take this opportunity to say that Hill has a monthly meeting, hybrid meeting. You can attend by Zoom or in person. And it's an organization of somewhere around 40 different agencies and persons, all the way from someone who is actually in recovery up to state level. We have state level participations in those. In addition, this next meeting is the 11th, and if you're not on it, don't have, we'll be glad to add you to our mailing list so that you have the opportunity to join. It's at Monday the 11th at 5:30, and usually lasts about an hour and 15 minutes. At the same time, we have set for July the 28th, a Thursday, what we're calling Recovery Central, which is bringing in all the different agencies that provide services to set up tents, bring your own tent, and be able to talk about, provide information, whatever you have concerning substance use disorder. We're expecting 500 to 1,000 people to attend that. There'll be a march through the town, and that's in conjunction with a Live It Out concert that'll be going on, and also a farmer's market. There's a free meal with it being put on by our commercial kitchen that's known as Kane. And the governor has already confirmed that he will be in attendance at that meeting. And that starts at 4 o'clock on the 28th. Certainly there's two different things from substance use disorder. We'd love to have you participate. Just follow us, whichever you want to do. You can send any of us an email. So that's kind of where we're with that new business, and we will get to that in a minute. Is there any questions about that then? All right, we go to number 6, which is general discussion. I don't see on here, we usually make some special time for Veronica to tell us what's going on in DMS and share with us anything that she would like to use this forum to share.
Oh gosh, so now my brain is really in overdrive, Mike, because I wasn't prepared for that, but thank you for the opportunity. Let me think. Right now we are still evaluating and working on implementation of any of the pieces of legislation that may affect DMS. And so we'll, as we determine those next steps as they affect providers, we'll certainly be sharing that information in more detail. We are, today, Commissioner Lee was presenting to the Medicaid Advisory and Oversight Committee to talk about, and Leslie Hoffman, our Deputy Commissioner, talk about two things. One has to do with our waivers, our 1915C waivers, and our 1115 SUD waiver. As you all may know, we are still waiting for CMS to approve our pending 1115 amendment that has to do with incarceration. We're in the middle of discussions with them on budget neutrality, which is a key piece of getting approval from CMS on an 1115 waiver. So we do believe that, once we're going to be optimistic, and I'm going to say once it gets approved, I think that will open the door for, that has both a pre-hearing component and to it to try to divert people away from incarceration, as well as for those that are incarcerated to increase the number of slots that have that's available to those who are incarcerated to get treatment and connection to as they're starting to be released, connection to community resources through our managed care organization. That's going to be a kind of a key piece to that. So we're again, awaiting approval for that. Lots of discussions still ongoing with CMS. Unwinding, which means that, once the public health emergency ends, right now we are required to have continuous coverage of folks, even if their eligibility does change for some reason or another. The only reason we can end somebody's participation in Medicaid right now is if they move out of state, if they make an actual request for us to terminate their eligibility, or if they pass away. So if you recall, we have added over 300,000 people to Medicaid since March of 2020 as a result of we're being required to continuously cover those folks. When we start to unwind, which will happen when the public health emergency ends, and my crystal ball can't tell me when that's going to happen. What we do know is that it was originally scheduled to end on July 14th. We did not receive the 60-day notice from CMS that they have promised states. So we anticipate it's going to be extended for another 90 days, which puts us into October. But we are, getting everything ready to flip the switch in the event that starts to end. As part of that is a lot of communication. We're have a communication strategy that makes sure providers understand how this affects them. Because, there are some flexibilities that we've been utilizing as it relates to provider enrollment, how services can be delivered, where they can be delivered, as well as I'm blanking on the name. Every 5 years, you all have to go through basically a renewal. So all those things have been on hold. So as soon as we get the 60-day notice, we'll start communicating out to ensure that everybody understands what the impact of that, both to the provider and the member. Our number one goal for unwinding the public health emergency is to prevent unnecessary administrative termination. So, somebody's kind of caught up in the back and forth of submitting additional information to us to renew their eligibility. And then also to ensure that they can move, let's say now they qualify for a qualified health plan on the exchange, that there is a smooth transition from Medicaid to another coverage, be it the QHP or some other private or employer insurance. So we continue to do a lot of work around that. That's a lot of system changes, and again, a lot of creation of communications and ensuring that we're capturing everything and we're staying in compliance with CMS. Let's see. So I think those are kind of the key pieces of things that the department's working on.
Okay. At the last meeting, you were talking about the route work group update, and you were talking about the ability of the MCOs to report out from Kentucky Health Net on the route that gets generated from the encounters they submit. But at that time, you said that there had been some hiccups and it was not active pending some testing. Is that status changed?
I believe that has gone live. Yes. And the RAP work group meets, I think next week. And the primary, agenda item on that is the MCOs have been meeting to look through consistent, to bring some consistency to the processing of claims and reduce some of the, the primary reasons why, we're having trouble with getting that claim through as an encounter and to generate a RAP. So we're looking forward to hearing how that sub-work group's been doing.
Okay, and just for the members present, I have that your Medicaid work group is on the 13th at 10 a.m. Okay. I also don't see on this agenda the MCOs. So at this time, let me go through that, and if you're in a position to do so, we'd like to know about the SUD benefits that you have. If you're not, or if you prefer, if you could send that to us in some type of a written format where we could compile it, would either way would be appreciated. To that end, Humana, that's usually Beth Day. Are you on here, Beth? Is anyone here?
Beth, this is Dr. Galloway. Beth has actually moved to another line of business. I think Felicia's on here to give the update, but I'm happy to kind of go over our SUD benefits before Felicia jumps in. Actually Medicaid covers just about every SUD service except for sober living is not actually covered under the Medicaid covered services. So your all your inpatient, your residential treatment, the outpatient treatments, which include the intense outpatient treatment, or your MAT treatments, which is both the methadone and Suboxone, are covered by Medicaid. Partial hospitalizations are covered. Peer support services, the different therapies being family, individual, and group therapies are covered. And Humana has some specialized services for our pregnant women for SUD treatments.
You have benefits such as assistance on transportation or other types of services along that line?
I would have to check on that, Mike.
Okay.
I know that, the traditional non-emergent transportation is a carve out through the state. I'm not sure if we do any kind of value added on that or not.
Okay.
In addition to the carve out.
Okay. You and the other MCOs, if you all could provide us that information, it'd be very helpful. And and by us, KPCA, I would love to see it myself. And my email's lmcaudle, CAUDILL at mtncomp.org. Do you have anything to report on behalf of Humana? None said related.
I will turn that over to Felicia. Thank you.
Okay.
Hi, this is Felicia Wheeler. There are no updates for today.
All right. So I'll make sure to ask for you next time.
Okay.
Okay. Well Care, Johnny Akers. Johnny, are you on?
I am, Mike. Hope you're doing well today. So regarding SUD, our BH director, Paula, is on. So Paula, if you want to share with Mike and the TAC our initiatives regarding SUD.
Sure, it's very similar to the Humana discussion. I will check on transportation. We also have a program we're working with for pregnant females that are substance using and their, the baby's outcomes. So we can send you some information by email like you requested on our SUD initiatives.
Okay. All right, Johnny, you have anything else you want to talk about from your standpoint?
Yeah, one more thing. As I've shared in the past, every other Friday at 1 p.m. Eastern, I've been hosting for several years a well care informational webinar. Tomorrow, Andrew Bledsoe from K-High is coming back to join us. I usually have him on at least about 3 times a year to give us a K-High update. So if anybody needs that invite, happy to send it to you. Thank you so much.
If I could,
All right.
this is Paula. If I could have one more go back, we are working, the whole MCOs together are working on a process to assist people that need the IV antibiotics for various conditions, but do not need acute inpatient medical hospitalization, transitioning to a substance abuse residential treatment facility. So we are working with globally with all the MCOs on how to manage that with some of our providers that can provide residential treatment and also provide an IV antibiotic for the members.
We
Okay.
appreciate the MCOs working together on that.
Mhm.
Hopefully that will be a precedent that we can do other things like that as well in the future.
Then let's go ahead to Aetna, and Becky Markhams spoke last time.
Good morning, Mike. Can everyone hear me?
Good morning.
How are you? I hope everyone had a good 4th. For that SUDS program, I'll have to take that back to the network, and we will email you all of our benefits and everything that's going on with that. So I'll get back with you on that because she's
Great.
out PTO this week. And some updates that Aetna has, we have something very exciting going on August 27th through the 28th. We have partnered up with RAM, which is Remote Area Medical. We're going to provide some vision eye exams, glasses made on site. We're going to do some dental cleanings, fillings, and some extractions. We got the medical. We're going to do general exams, women's health, and much more. So that's going to be August the 27th through the 28th. That's going to be at East Ridge High School, located in Lick Creek, Kentucky. So that's going to be very good for all of our members that live in Letcher, Perry, TAC, and Floyd counties. One more thing that we still have going on is our virtual office hours for the providers. That's going to be held every last Thursday of each month from 11 to 12. And if anybody has any questions or wants some more information, I will put my email in the chat. That's all I got.
Thank you.
Thank you.
Now go to the Molina. Shelley Pfeiffer, I believe, was on here last time. You on this time, Shelley?
Mike, this is Courtney Kelly, and I'm on for Shelley Fife. Shelley has moved on and been promoted within the company, and so I'm going to be her backfill for a little bit until we are able to hire somebody. I'm one of the managers in our provider services team at Passport by Molina, and I will make sure to send you all the information we have related to SUD benefits. That way it's comprehensive and all in one package for you. And then as it relates to any other updates we do have some quite a few updates going and things I wanted to announce. Number one is that we are having our ribbon cutting for our Bowling Green One-Stop Help Center this Friday at 10 o'clock. In Bowling Green Central Time. And so I'm happy to send that information and all those details. We do plan to have a vaccine event at this time, and any provider and member are welcome to join. We're looking forward to it and to opening it up to the community now that we've got some COVID restrictions lifted and that type of thing. So that's one thing we're really looking forward to. Another item we recently made an update or sent an e-news regarding was an update to our paper claims and appeals and grievance address. That is changing. And so just wanted to make sure that those on the call received that. If they're a provider within the network, the paper claims address is changing. And if you need that information, again, like I mentioned, I'll put my information in the chat as well if you need to reach out and get that additional information, but that is posted on the website. And then we also are newly partnered with a company called Progeny. And so this company specializes in neonatal care management services. And so we're looking forward to that partnership with them and collaborating to kind of create a program that hopefully will enhance the services for the members and support, obviously, our mission of making a lasting difference in the members' lives by improving their health. So those are just a handful of updates for now. And again, if there's any questions, I'll put my information in the chat.
All right, thank you. Any questions of Courtney? All right, thank you. United, last time Dr. Cantor was speaking, who will be speaking for United today?
Sorry, good morning. This is Dr. Adam Rich. Dr. Cantor wasn't able to be here this morning, and so I just have a few brief announcements. Neither was our behavioral health director, so we'll be sending the SUD report to you email and then for that. The only other note that I'd like to bring up is that we have a provider relations virtual event coming up the 12th of July, and I'd like to be able to get that flyer out to this TAC and to other providers. If I could share that with your email, is that the best way to share that with you?
All right, thank you. Any questions of Dr. Rich? All right, the last is Anthem. Stuart Cox addressed this last time. Who will be representing Anthem this time?
Hello, Mike. It's Brian Richardson with Anthem. We have a few updates to give. And the first one is we have some webinars coming up that we wanted to share with you guys. They're out on our website, so it's still anthem.com. And there's several of them coming up. On July 21st, there is Pregnancy and Women's Health for HEDIS. On August the 4th, we have a HEDIS for quality measures. And on August 16th, a follow-up for HEDIS quality measures. September 8th and September 21st, both of those are going to be for CPT Category 2 codes. And our last update is we want to let everyone know that we're expanding the COVID vaccine for members and for providers to 6 months forward. The SUD, I'm going to have to pass off to David for help on that one.
Sure. Hello, this is David Crowley, Director of Behavioral Health for Anthem. And just as all the other MCOs have stated, Department of Medicaid has an extensive array of SUD benefits available to our members. I think our state's really progressed in what's available for folks in SUD recovery out there. Just in addition to, we've really focused on expanding medication-assisted treatment access to our members, specifically in the rural populations. And over the course of the past year and a half or so, we worked with University of Kentucky Continuing Education Central Department to create a 7-hour workshop that's really an education session for primary care providers to get them more comfortable with using LAN, long-acting naltrexone medication-assisted treatment. And I can provide the link for that workshop, Mike, to you, and we can disperse it to other members of the TAC so they can utilize that resource. And we're really hoping that educational opportunity would kind of take off, especially in our rural health primary care setting providers, to expand long-acting naltrexone for medication-assisted treatment.
Hope it takes off also, David. For all the MCOs and Veronica for DMS too, we certainly would appreciate you all having representation at the Recovery Central event that's going to happen on the 28th. Bring your own tents and lawn chair, but we'll feed you. And we'll try to get a crosswalk up of the information from the different MCOs as we receive it, so that we have things that we can hand out to the people that'll be there. When I said there'll be 500 and more, that is, we're expecting 500 people in active recovery or wanting to become in recovery for that event. Any other items that any member would like to discuss under general discussion? Go to 7 on the agenda. Is there any recommendations to be presented to the MAC? I don't hear any, so we'll go to 8, which is MAC meeting representation. At this time, I will be attending that meeting, which is on the 21st at 11 a.m. according to my calendar. Our next meeting of this group is September the 1st.
Mike, if I may
Yes.
interrupt for just a moment, our next MAC meeting is on the 28th, not the 21st.
The 28th. You've wounded me deeply.
I'm so
Okay.
sorry.
No, my bad. And thank you for correcting me on that. So it's on the 28th, a week later than I had.
That's what I had too, 28th.
Okay. So I will be in attendance on that virtually. All right, next meeting, September the 1st, 2022. Before I ask to adjourn, does anyone have anything they would like to discuss, comment, or ask? Having heard none, thank you all for being here. I will say that for KPCA, David Boat has retired, and Molly Lewis is acting as the interim CEO at this time until a permanent appointee can be made. That's all I have. There's a motion to adjourn.
This is Chris, is a motion.
Chris has
Second.
made the motion and seconded by
Barry.
Barry. Thank you, Barry. All right. All those in favor say aye.
Aye.
Aye. All right, everyone have a great day.
Thanks, you too.